Good afternoon, and thank you for allowing me to present our work on implementing robotic surgery in the acute care practice. I do not have any disclosures. So acute care surgery is really rooted within trauma surgery. In 2003, the AAST defined the practice, initially encompassing trauma, critical care, and emergency surgery. The reason behind this was a concern for a lack of general surgeons as well as trauma surgeons. This was a way to redefine the general surgeon. With further evolution, the ACS practice has additionally added elective surgery as well as surgical rescue to be a part of their core pillars. So EGS procedures continue to increase year after year. Although only representing about 11% of procedures performed annually, they have disproportionately high risks of complications as well as mortality. Research within the EGS field has found that minimally invasive techniques have decreased this complication rate, mortality, and have shorter length of stay. All of this which can lead to a decrease in healthcare expenditure. So robotic surgery has been slow to be incorporated within the ACS population. Robotics was predominantly established for elective procedures. While not all patients are actually able to undergo minimally invasive procedures due to medical conditions or emergent need for a case, a few studies have looked at robotic procedures within the urgent and emergent settings. In 2010, there were only 10 retrospective studies performed, and all of these were from non-ACS surgeons. And in 2022, only 4 retrospective studies were performed. We really wanted to see what the feasibility of performing robotic procedures within the pillars of ACS was. So our goal was to evaluate the feasibility of incorporating a robotic surgery within our institution. This is a single healthcare system composing 9 hospitals within our region containing ACS-trained physicians who have robotic privileges. Our study consisted of adult EGS patients who underwent emergent, urgent, subacute, and elective robotic procedures from April of 2022 to June of 2023. As noted, all the physicians had robotic privileges and were within our ACS network. Common procedures included appendectomies, cholecystectomies, colectomies, ventral and inguinal hernia repairs, as well as the occasional lysis of adhesions and perforated ulcer repairs. Data collected included patient demographics, ASA score, hospital length of stay, total operative time, predicted length of stay, conversion to open, total supply and implant charge, as well as mortality. Our primary outcomes were hospital length of stay, and secondary outcomes were 30-day readmission and mortality. So emergent procedures were listed as being performed within 24 hours. Urgent procedures were after 24 hours, but within that patient's hospitalization. Subacute procedures were patients who were seen in the emergency department, deemed stable enough to go home, followed up in the outpatient setting, and had surgery within 30 days. And elective procedures were either referrals from outside providers or patients who were coming to be seen from sequela of prior ACS operations, including trauma operations in which patients had reversal of their ostomies as well as repair of ventral hernias. The total supply and implant cost, this is actually calculated on Epic, and it only includes disposable materials and not staff, anesthesia, or any hospital costs. So we had 200 patients undergo robotic procedures in our time frame. The median BMI was 29.9, and ASA class was usually 2 or 3. You can see the procedures that were performed to the right, the majority being cholecystectomies and hernia repairs. Here you can see the case classification breakdown. The majority of our cases were subacute and elective procedures, although we did have an increase in the amount of urgent and emergent cases as our later in the study period in 2023. So when looking at our total, so here are the urgent and emergent case types. The inguinal hernia repairs and ventral hernia repairs were able to be performed in the urgent and emergent setting, but most were cholecystectomies as well as appendectomies. Looking at the total supply and implant charge, so for all of our cases, the total supply charge was just under $1,800. You can see that inguinal hernias and cholecystectomies were cheaper. And to put it into comparison, for a traditional laparoscopic cholecystectomy, these charges hover usually around the $600 to $900 range, depending on what instruments are used. Looking at our length of stay, for all procedures, the median length of stay was 1 day, but included 157 outpatient procedures or patients who were in observation. For those with inpatient status, the mean length of stay was 3 days. Using Premier data, for only our inpatient procedures, the predicted length of stay was 3.1 days, this giving us an O to E ratio of 0.97. Our 30-day readmission rate was 2.5%, and we did not have any mortalities. Not listed, but only 2 cases were converted to open procedures. Here you can see a breakdown of the operations as well as the median hospital length of stay. This was when the patient was either presented to the emergency department or presented to the preoperative setting to undergo their procedure. So in conclusion, robotics in ACS is growing, remains feasible, and can be performed in the urgent and emergent setting. On top of this, as surgeons become more comfortable with robotics, the complexity of cases being performed can expand, and more AGS cases may be able to be performed in a minimally invasive setting instead of having to convert to open procedures. Future directions include expanding our utilization within ACS, including trauma surgery, having 24-hour access to the robot, and ultimately a multi-center trial comparing laparoscopic and robotic outcomes. Thank you, and I'll take any questions.